Okay, good morning everyone. So today we're gonna be discussing a little bit about the IB fluids. No, and tomorrow we're gonna be discussing about the computation itself. So for today we are gonna be discussing a brief discussion about IB fluids, like our sodium electrolytes. No, and then we were gonna discuss our IV fluids. No, ayan. So we're gonna tackle both of these two. Okay, starting with our definition of terms. Now, what is an electrolyte? Now, an electrolyte these are what we call substances. Okay, let me write. Ayan. No? These are substances that contain charged ions. Charged ions that conduct electricity. That conduct electricity. Yan. When dissolved in a polar solvent. In a polar solvent. Okay? Like water. No? Like water. Water is a solvent. Now, what are examples of our electrolytes? We have a few, no? We have our sodium, our potassium, what else? Our calcium and magnesium. Okay, muna siya ang mga major ones. Now, these four are the major electrolytes, no? So what are the functions of these electrolytes? Actually, there's many class, no? And it's per electrolyte they have very different functions, but basically it all boils down to fluid balance. They are required for fluid balance. They are required for nerve and muscle function. Muscle function. What else? Acid-base balance. Acid-base balance. Yan. Nutrient and waste transport. And heart function, obviously, no? Heart function. Ayan, no? So those are its major functions of our electrolytes. Now, if we continue, no, let's talk about our solvent. Solvents class, these are our substances that are dissolved, no? Substances capable of dissolving. Substances capable of dissolving. Okay, our example for this one is our water and plasma. Plasma in the blood, no? Plasma in the blood. While our solute are substances that are dissolved. Substances that is dissolved in a solvent. Okay, for example, class, our electrolytes and proteins. Electrolytes and proteins, no? Next is our tonicity. Okay, now when we say tonicity, this refers to the relationship between the concentration of of solutes between two compartments. Okay, later on we will discuss compartments. Okay, just take note of the key term here. Ang key gid ani class is it is the relationship between the concentration, no, of solutes. That is the relationship. No, we're referring to two concentrations, no, when we're talking about tonicity. Okay, later on we will discuss more. Next is our osmolality. Now, osmolality, technically speaking, is the number of osmoles per 1 kilogram of fluid. Now, the reason why we are using osmolality instead of osmolarity, okay? keep that in mind. Osmolality instead of osmolarity is that this is the best indication. Best indicator for fluid concentration. Okay? The reason why is because this is thermodynamically stable. Meaning to say, regardless of the temperature, no, it will remain consistent because we are using weight instead of the number of fluids, no? Naman ko gitawag class nga kuan class. We also have what we call our osmolarity. Osmolarity. Now, kining osmolarity, this is the number of osmoles per 1 liter of fluid. Now, the problem with that is, no, fluid man good can expand or shrink depending on the temperature. So, the volume is not a very good indicator. Whereas weight man good class, it tells us that even if ni-expand siya, or even if it expands or depletes, no, if the weight is consistent, then this is a very good indicator because it's dynamically stable. Now, when we are talking about osmolality, normally it should be around 275 to 295 milliosmoles per kilogram. Okay, mo na siya ang normal. Okay? Now, there is a term that you will hear me talking about, no? It's serum osmolality. Okay? Now, class, to simplify class, no, this osmolality basically means, what it basically means is concentration. Okay? Unsa ka concentrated or how concentrated a fluid is, no? So, when we say serum osmolality, it's referring to the concentration of solutes in the blood. Okay? Yan na siya, class. It's the concentration of solutes in the blood. Now, let's talk about homeostasis, no? There are two principles that stand out when considering homeostasis in fluid and electrolyte balance. The first principle is that the electrolytes must be balanced within each compartment and remain electrically neutral. And the second principle is that the fluid compartments remain in osmotic equilibrium. Basically, what this refers to is there is a balance, okay, between both fluids and electrolytes. Okay? There is a balance between that fluid and electrolyte, no? Now, how do we achieve this balance? How do we achieve this balance? This balance is achieved, no, this is achieved through the movement of fluids and electrolytes. This is achieved through the movement of fluids and electrolytes between compartments. Okay, between compartments, no? So there is a lot of mechanisms involved when it comes to movements, but let's talk about our compartments first, no? Sige, tag-discuss og movement o pata mag-discuss og compartments. Okay? Now, there are two major compartments, no? Body fluids, no? Water and ions dissolved in it are distributed in two major compartments. First is the intracellular fluid compartment. When we say intracellular, class, this is the fluid compartment inside the cell. So, this is what we refer to as the inside of the cell, no? Pasig naglibog buma, sir, what is a compartment, sir? Okay? A compartment is just a kuan class. It is a what we call it is a structure that holds fluids, di ba? No? So when we're talking about intracellular, it refers to the inside of the cell. Okay? The inside of the cell holds the fluids. Now, when we're talking about extracellular class, this is what we call the outside of the cell. No? Outside of the cell. And this is further subdivided into two categories class. Okay? Actually, this is divided into three, but we're gonna discuss more on two today. No? The interstitial and the intravascular. Intravascular. No? When we are talking about the interstitial, it refers to between the cells. This is the fluid compartment between the cells, while the intravascular is the fluid compartment inside the blood vessels. Ayan, inside the blood vessels. Now, this is very crucial, no? Because understanding of both is important for what we call our fluid and electrolyte balance. Okay. Now, let's talk about the movement of solvents first. Remember, when we're talking about solvents, we are talking about water and plasma. So, this is talking about the movement of water and plasma. Now, there are two, no? We have hydrostatic pressure and osmotic pressure. Okay? Hydrostatic pressure refers to the force the fluid exerts on the blood vessel walls, pushing fluids out. So, let's say, for example, class, this is your blood vessel. Okay? Ako na lang i-read so that it's much easier to understand. This is your blood vessel. Okay? Now, remember, as what I've told you before, no, that fluids tend to push against the blood vessel walls. This is highly dependent, no, on several factors, and this is what we call our blood pressure. Diba? This is our blood pressure. Now, the higher the blood pressure class, no, there is a tendency that the fluid that is pushing against the blood vessel walls will exit, no? The water will exit. No, the water or the plasma, it will exit. That is what we call our hydrostatic pressure, no? Because there is a force that exerts on the blood vessel walls, similar to your blood pressure, no? So manggawa siya. Now, is that bad? Yes, because if fluid leaks out, no, if water leaks out of the blood vessels, then you will suffer from what we call dehydration. Diba? You will suffer from what we call dehydration. Okay? So, the body has another way of compensating it, and that is our osmotic pressure. Osmotic pressure counteracts hydrostatic pressure. This is the pressure created by the pressure gradient caused by osmosis. I want to highlight that, Now, here's what happens, no? In your blood vessels, class, there are proteins called albumin. Ato ni butang o green, no? There are proteins called albumin. And there's a lot of that inside your blood vessels, no? While outside the blood vessel, kaya ito i-label, this is the blood vessel. This one is the interstitial. Okay? Interstitial. Kani nga rin, kini siya class, this is the intracellular. No? Intracellular, no? While in your interstitial, intracellular, there's still albumin, there's still proteins, but very few amount. Now, because of that, class, because there is very few, no, there is a tendency. I will put it in yellow. I will put it in yellow that solvents will move from an area of low solute concentration, pareha ani class, since there's very little proteins, very little solutes, no, to an area of high solute concentration. So what happens there is the water will enter your blood vessels because it is being pulled by the large amount of solutes. Or albumin. Diba albumin? No? Albumin is a protein, okay? H2O, no? And the plasma. So what happens there, class, is there is equilibrium. Diba? Equal na sila. There is a pulling force, there is a pushing force, no? So this is the movement of our solutes, no? Remember, kanina itong mga green ha, muna siya itong mga albumin, no? Yan, albumin, no? Obviously, there's a lot of it in our blood vessels. Okay? Next is the movement of our solutes. Now, when we are talking about solutes, we are now talking about the proteins and electrolytes. No? Proteins and electrolytes. Okay. Now, there are two main mechanisms. First is our diffusion. No? Yan na siya class. Let's say, ato to during balik this is our blood vessel. Okay? This is our intravascular space. Kini siya kay interstitial. And this one here is our intracellular. Inside the cell, no? Intracellular. Now, let's say for example, class, sodium atong i-discuss today ha, sodium ha. Let's say for example, there is a lot of sodium in your IV, intravascular, no? Daghan og sodium dire. No? No? Okay. There's a lot of sodium, no, compared to your intracellular. So what happens there is the body, no, through a what we call a concentration gradient, will try to equalize the amount of what we call our solutes. So if I will count this one here, 1, 2, 3, 4, 5, 6, 7, 8, 9. 9, okay, 9. Pati man class ato, punan o usa pa. Okay, so 10. Okay, and then inside, there is 6. No, 6. So what happens there is, through diffusion, the solutes move from an area of high concentration. Nga dire, it's highly concentrated because there's a lot. No? There's a lot. To an area of low concentration. Nga padong here because there's not a lot. No? So what happens is, a few of these solvent or solutes, no, will move towards the interstitium. Okay, it will move towards the interstitium. Okay, and now class, no, it will move towards the interstitium and then it will move towards the intracellular. Manood na sila diha class, they will now transition, no, into that. Now if you count the number of particles, there's an equal 8, and that is what we call our balance. That's what happens when it comes to diffusion, no? From an area of high concentration, high solute concentration, to an area of low solute concentration. Next is active transport. Now when we're talking about active transport, this refers to the movement of solutes using energy using processes. So, an example of this one, class, I think you are very familiar, if you have listened before, is the sodium-potassium pump. Okay? Sodium-potassium pump. Diba? It's very important, class, no, that we understand the function of the sodium-potassium pump. Okay? So that is an example lang, di ba? So these are our normal electrolyte levels. No, this is already in your PowerPoint, so you can read about it. No, the functions are also there as well. I just want to highlight the fact that in every compartment there is a major anion and cation. No, every compartment. Okay. Now for our intracellular, there are two major electrolytes. Okay, the first major electrolyte in the intracellular space is our potassium. Okay, our potassium and our magnesium. While for the extracellular, outside the cell, extracellular, it is our sodium and it is our calcium. Okay, sodium and our calcium. Now our sodium class, no, this is what you need to remember. It's around 135 to 145 milliequivalents per liter. Our potassium is 3.5 to 5.2 milliequivalents per liter. Our calcium is 8.9 to 8.5 to 10.5 milligrams per deciliter. And our magnesium is 1.6 to 2.6 milligrams per deciliter. And we also have our phosphates and our chlorides, no? Kini sila class, our phosphates and chlorides. Our chloride specifically is an anion. Anion in the It is an anion in the ECF. Okay? Extracellular fluid. This means chloride class is negatively charged. Okay, negatively charged. While our phosphate class is the anion, it is the anion in the ICF or intracellular fluid, no? Intracellular fluid. So this is negatively charged as well. While the rest, no, kining sodium, potassium, these are what we call cations. Okay, they are all positively charged, di ba? Cations. Okay, cations, no? No, so basic chemistry. Okay, so let's talk about the next part, which is our further readings. Now, class, I want you to read about electrolyte replacements on sodium, potassium, magnesium, and calcium, no? Most of the time, I think I did not include this in the exam. Although, I just want you to read about it because this is a common topic in your MS. No, this will be discussed in your MS. Because technically, they are not, technically, they are drugs, no? But technically also, they are more so treatments. Now, so for sodium class, what I want you to read about is sodium bicarbonate. Sodium bicarbonate. And what else? Sodium chloride. Sodium chloride class, if you look at its chemical composition, it is NaCl. Basically, it's table salt. You know? It's table salt. Table salt in medication form. Naingana class eh. For our potassium, we have to check our, you have to read about your potassium chloride. Potassium chloride. Okay, for our calcium, it's our calcium gluconate. Gluconate. And calcium citrate. Calcium citrate. And then our magnesium, we have our magnesium, what else? Chloride. Okay? So these are our electrolyte replacements. They will replace your body, they will replace the electrolytes in your body if, for example, there is lacking electrolytes, no? So let's talk about our IB fluids next. That was our brief discussion on the electrolytes. So our colloids and crystalloids. Now, what are our colloids? Let's talk about our colloids first. Colloids are solutions that contain large molecules that don't pass the cell membranes. When infused, they remain in the intravascular space and expand the intravascular volume by drawing fluids using their oncotic pressure. Okay? Now, it's very similar to what I explained before, class. If this is the blood vessel, okay, and this is the interstitial space, blood vessel siya, and this is the interstitial. What happens there is this, okay? Listen to your anatomy, ha? Listen to your anatomy. Colloids, class, contain large molecules. Most of the time, class, these molecules are albumin. Okay, listen to me, ha? Albumin, no? So, butang nila class, no? They will put large albumin. Okay? When you give a colloid. Now, because this albumin cannot pass, no? They cannot pass the blood vessel membranes, dili sila katabok, no? What they will do is instead they will pull water from the interstitial and from the intracellular towards your blood vessel. No, they will pull water. No, iyan abirahon ang tubig. In turn, class, here's my question, will it increase your blood volume? Yes, so there will now be an increase in blood or plasma volume. Okay, there will be an increase in blood or plasma volume. Now, because of this action, no, colloids are used for fluid resuscitation to increase the fluids in your intravascular resuscitation. This is also used as protein replacement because we are mostly infusing albumin. Albumin is a protein. Okay, and most importantly, class, this is for volume expansion. Okay, we are expanding the volume. Okay, expanding the volume of the intravascular fluid. Okay, so that's our colloids, no? So what do we need to remember when it comes to our colloids? Monitor the patient for fluid overload. Since you are trying to expand or increase the fluid volume, then there is a chance that the patient will get fluid overload. So what do you need to do? You need to watch out for crackles. Okay? Edema. Crackles, auscultate crackles in your lungs, no? Edema and an increased heart rate and blood pressure. These are common signs, no, when it comes to our fluid overload. Dagan pa ka na sa science class, no, but mostly class kining duha, crackles and edema. These are the crucial ones that you need to check, no? Kini mago siya class, increased heart rate and BP. These are early signs, no? Early signs di siya. Okay, infuse colloids with 18 gauge or larger needle. Remember, in your IV administration, the larger the gauge, the smaller the number. So 18 gauge or a larger gauge is 16, no? 16G or even 14G, no? You'll learn more about this when you have your demonstration on IV priming. Okay, and monitor the patient's coagulation indexes. When we say coagulation indexes, what we are referring to is we need to monitor the patient's platelet count, PT and PTT, or our prothrombin time and our partial thromboplastin time. Okay, nga naman, because colloids mong good class, colloids interfere, why, no, with platelet synthesis and function, no? They interfere with platelet synthesis and function. So ato na yung check, no? We need to hold ACE inhibitors for at least 24 hours when giving albumin. We need to hold ACE inhibitors because this can cause, no, what we call atypical risk for atypical reactions. Okay, which will include flushing, kana bitong mamuwa imong face, redness of the face, no, flushing and hypotension. Okay, hypotension. So ayan, this is contraindicated, these drugs or colloids, no, for patients with severe anemia and patients with heart failure. Do not give these colloids, no, to these patients. Okay, especially kind of heart failure class, no. The problem man is if you have colloids, if you're gonna give colloids to a patient with heart failure, then you're gonna increase the blood volume by a large amount. And remember, in heart failure, the problem in heart failure is that your blood or your heart cannot pump the blood effectively. So you're just gonna make it work harder. No, you're just gonna make the heart work harder for something that it's not supposed to do, di ba? Or something that it's supposed to do, no? So, mo na siya. That's why lagyan natin yan malaking star class, baka lalabas yan sa exam, di ba? Okay. Okay, next is our crystalloids, no? Wait sa. Okay. Crystalloids are solutions that contain small molecules that flow easily across compartments. Allowing for the transfer from the bloodstream into the cells and blood tissues and vice versa. No? Vice versa. They can be divided into isotonic, hypotonic, and hypertonic solutions. Okay, now listen to me, ha? Okay, let's talk about isotonic first. This is when the osmolality, when we say osmolality, let me repeat it again, we are referring to concentration. No, we are referring to concentration of solutes, okay, of the fluid is equal to the plasma. Meaning to say, the concentration in your intracellular fluid is equal to the one in your extracellular fluid. Equal ra ang ilang concentration. Therefore, there will be no solute movement. It only increases intravascular volume and replenishes electrolytes. So it's like this. I will draw it for you, okay? So that you will understand, no? Okay? Let's say, for example, this is your blood vessel and this is your cell. At sa tapad class, no? In between them is the interstitial. Okay, it's like this. Okay? Now, let's say for instance, class, colors there. Let's say for instance that there is sodium, no? There is, let's say 6 sodium. No, 6 sodium particles inside your cells. Okay? There is also 6 sodium particles in your blood vessels. This is an isotonic solution. No? An isotonic solution is a solution that is very similar. Okay? Very similar. Listen to me, ha? Very similar in what we call composition, no? Very similar in composition to blood. So they will just equalize in the blood. So what happens there is this: since there is an equal amount, no, equal amount, there will not be osmosis. Okay, so there will not be movement, walay water movement from the blood vessel to the tissue, out to the cells, and there will be no movement from the cells to your blood vessels. So wala. So there is equal. So what happens there is you are just infusing electrolytes. Nagbutang ra kag electrolytes ka sa imong blood vessel. That's why we use these drugs to replenish electrolytes and increase volume. You're just infusing, no, something that is very similar to your blood. It's very similar in chemical composition to your blood. So equal amount. Okay? So we have Kuan class. We have 3 major types of isotonic fluids. We have our 0.9% sodium chloride. Okay, 0.9% sodium chloride. Okay, we have our lactated Ringer's solution. And we have our dextrose. Wait. Dextrose 5% in water. Also known as our D5W. D5W. Okay, now let's talk about our sodium chloride first, also known as our normal saline solution. Diba? You already know this. NSS, normal saline solution. Okay? Normal saline solution is due to the percentage of sodium is equal to the percentage of sodium in the intravascular space. So equal na the amount of sodium in your NaCl or your sodium chloride 0.9% sodium chloride is equal to the amount of sodium in your intravascular space, or relatively equal, no? So we often use this for fluid volume deficits, shock, no? Used with blood products. How let's discuss one by one, no? I have to discuss one by one, class, no? When we say fluid volume deficit, this is caused by bleeding. Okay, this is caused by, so we're gonna give this our 0.9% sodium chloride if the patient is bleeding. Indications man eh. Indications, okay? Bleeding, diarrhea. Yay. Diarrhea. What else? Heavy drainage from suctioning. And what else, no? Lack of water intake. Obviously, you will become dehydrated if you're not gonna drink, no? So basically, fluid volume deficit, it's just dehydration, no? Shock, class, no? Shock is a sudden drop of body fluids. This is a sudden drop of blood volume, actually. Blood volume, no? So, ang major cause, ani, class, is bleeding, di ba? What else, no? Another cause of this one could also be hypotension. What else? Another cause could be infection. Infection. We have what we call septic shock. What else? Another would be neurologic causes. Neurologic. Okay. This is often used with blood products. Meaning to say, class, no? This can be mixed. Lagyan mo yan ng malaking star, ha? Lagyan mo yan ng malaking star, no? This is often mixed with blood products. When we say blood products, what I'm referring to is kind of the things that we transfuse. Like, for example, packed RBC, no? Packed RBC, fresh frozen plasma, fresh frozen plasma. Basically, what we transfuse, no? Mixed with blood products. Okay? I think they are the only one that can be mixed. Okay? These are the only substances that can be mixed with blood products. Okay, fresh frozen plasma. What else? No, anong platelets? Platelet infusion. Platelet infusion, and this can also be used for patients with as a fluid replacement. Now, since this is a patient with, this is indicated for fluid replacement, then caution. Okay, caution when giving this to patients with cardiac and renal problems, no? Because these two might not be able to tolerate. Patients with cardiac and renal problems might not be able to tolerate fluid replacement, no? So it might cause, now there's a very high risk, okay, risk for fluid overload. Ayan, fluid volume excess, no? Next is our lactated ringers. This is most similar in composition to blood serum and plasma. This is the IV of choice for patient with burn injuries. Lagyan nyo yung malaking star, class, no? If naagani masunog, class, they will always prefer, no? Lactated ringers. However, class, dili na siya ikuan. We do not use this with our blood products. We do not use this with our blood products. The reason why is kuan, it tends good, class, to kuan, it tends to change the pH of the blood, no? So let's talk about our burns, no? The reason why lactated ringers is best used for burns is because burns good, class, tend to have massive dehydration. Okay? If masunog mga class, if most of your body is burned, massive dehydration. Massive dehydration. This is due to blister formation. Okay, blister formation. So there will be lots of fluid loss. We're gonna use our lactated ringers, no, because it's a very strong fluid expander. Okay, this is to replace GI fluid losses from diarrhea and vomiting, burns, as I mentioned before. And this is also used for acute blood loss and hypovolemia. When we are talking about hypovolemia, this is an overall decrease, no? This is an overall decrease in body fluids. Ayan, body fluids, no? So that is for our lactated ringers. Now, what do we need to consider when it comes to lactated ringers? Lactated ringers is metabolized in the liver, which converts lactate into bicarbonate. Now, bicarbonate, class, listen to me. Bicarbonate is a base, no? It is a base, no? So, class, we can use it for metabolic acidosis. Okay? This is to counteract. No, not counteract is not the right word. This is to what we call equalize, no? To equalize the acidity with bicarbonate. HCO3 is bicarbonate. Okay? However, class, this is contraindicated for patients with a pH greater than 7.5. Because if it is greater than 7.5, then it is already alkaline or basic. And if we are gonna give them LR, then you are just gonna further make it more basic. Okay, so they might suffer from alkalosis. We need to observe caution when giving this to patients with severe renal impairments. Okay, the reason why is because lactated ringers has high potassium content. Okay, and if nasa a problem with their kidneys, they might not be able to excrete this potassium, so it might cause what we call hyperkalemia. Okay, it might cause hyperkalemia. So that's a big problem, no? We already know that potassium is a big problem, especially hyperkalemia, because it might cause dysrhythmias, di ba? Dysrhythmias, balik na lang tayo na class, no? Next is our dextrose in water. Dextrose 5% in water is considered an isotonic solution, but when dextrose is metabolized in the bloodstream, it becomes hypotonic. So once the D5 water enters the bloodstream, it will become hypotonic. Now, we will talk about hypotonicity later, or hypotonic volumes. But the reason why this happens is very simple, class. Okay? The reason why this happens is very simple, because, class, when we say dextrose, okay? When we say dextrose, class, is just a simple sugar. Okay? Simple sugar. So basically, class, this is a form of glucose. No? So this fluid, class, is 5% glucose in water. No? So nasa sugar. Okay? Now, because of that, class, no, it is easily metabolized in your bloodstream. As we all know, glucose is metabolized in the bloodstream, no? It is broken down. Dextrose is broken down and it is converted into glucose. Diba? So, what do we need to remember? What do we need to remember? Number 1, never, lagyan mo yan ng malaking star, class, okay? Never administer D5 water with blood products. Blood products, no? You can put it in blood, but do not mix it with kanang pak RBC, kanang mga to mga kuan ba, mga pang-abuno ba, or kanang ato mga transfusion, ato mga blood transfusion products, no? The reason why is because dextrose, asa man to? Dextrose will hemolyze blood products. Okay? When we say hemolyze class, they will destroy, no? Another thing is that this solution should not be used for fluid resuscitation. Okay? It's because the solution, no, or the plasma or water will move around when it becomes hypotonic. Okay, later on I will discuss how it moves around, no? This will contain 170 calories per liter, but this does not replace electrolytes. So nani siya mga calories class. Okay? So what do we need to watch out for in hypotonics or isotonics in general? So watch out for signs of hypervolemia. We already know sa ito mga signs for excess fluid volume class, no? We have our crackles. Ato balikon lang ha. Edema. What else? Increased heart rate and BP. Let's add a few more, no? Bounding pulse. It's a pulse that is easily felt and very strong. What else? Jugular vein distension. No? Jugular vein distension is when your jugular veins are niburot, no, or it's expanded. No? This is possibly due to the rapid or over-infusion of isotonic fluids. We need to monitor the patient's intake and output. We already know that. Aside from that, we also need to monitor the patient's weight. No? Lagyan mo yan ng malaking star class. Okay? If the patient is dyspneic, if they have difficulty breathing, stop the infusion immediately and notify the doctor. Because dyspnea is a sign, okay, dyspnea is a sign of pulmonary edema. Okay? So, yeah, pulmonary edema. You can confirm though, imo siya i-confirm by auscultating for crackles, di ba? Crackles are present class if there is fluid in your lungs, no? Crackles are present if there is fluid in your lungs. Keep the head of the bed elevated 45 degrees. This will promote venous return. This is so that the blood, no, the unoxygenated blood returns back to the heart. Di ba? Okay, now let's talk about our hypotonic fluids. Okay? And I like this so much class, no? This is when the osmolality of the fluid is less than, okay? The osmolality of the fluid is less than the plasma. Okay? There is osmolality of the fluid is less than the plasma. No. Okay? Wait sa. This is a class. No. Sus, bali ni. Okay? When we're talking about hypotonic, ato i-reason na. Sorry for this. Ako i-reason. This is when the osmolality of the plasma, okay? Osmolality of the plasma is less than, maybe, that is what? Plasma. Oy. Osmolality of the, di maklaro. Plasma is less than the osmolality of the fluids in ICF, intracellular fluid, no? So kana mo na siya. Therefore, fluids will move from the intravascular to the intracellular. These solutions are used to hydrate cells, okay, but deplete fluid in the circulatory system, no? Deplete fluid in the circulatory system. So what it does is like this, no? Ato balik ko na. Ato i-drawing diri. This is your blood vessel. Okay? This is your blood vessel and this one is your cells. Okay? Now, as I mentioned before, a hypotonic solution is a solution wherein there is increased solutes in the cell. Oh, tanawa, plasma is less than the fluids in the ICF. So it means to say the fluids in the ICF have greater concentration, no? Solutes in the cell, there's increased solutes in the cell, no? Compared to blood. Mas daghan og solutes dire. So it's like this, no? Let's say, for example, this is our solutes. Let's say this is our sodium, no? There's 6, okay? And let's say nga kay 1, 2, 3, 4. If I am gonna ask you, which one is more concentrated? Di ba kini nga re? No? Because there's a lot more solutes here. Mas daghan og solutes. So what happens there is this, okay? Water from the what we call intravascular space will go towards your intracellular space. No, water, okay, and also plasma will go to your intracellular space. Now what happens there is this. Since there is now a lot of water in your intracellular space, your intracellular space will now expand. Mudako na sa class, no? It will now expand because there's lots of water there anymore, no? So in theory, no, hypotonics will make the cells swell. Okay, the cells will swell, no, because there is a lot of fluid, no? Osmosis, no, mo ni siya, no? Osmosis, the moving theory moves water and plasma from an area of low concentration here, okay, to an area of high concentration. So padung sa imong cells, which will make the cells swell, no? So it will hydrate the cells, the cells, no? Because you are putting a lot of fluid in the cells, okay? But it will deplete the fluid in the circulatory system, so there will be a decrease in blood volume. Keep that in mind, ha? There will be a decrease in blood volume. Ayan, double colors, oh, no? So keep that in mind. That is what happens with our hypotonic, okay? So we have 3 hypotonic solutions, our 0.45 sodium chloride solution, our 0.33 sodium chloride solution, and our 2.5 dextrose in water, no? These are indicated for patients with hypernatremia. Hypernatremia, my good class, no, because we want to decrease the volume of sodium, And normally, class, ang volume of sodium is 0.9. We're gonna give them something lower. Okay? Diabetic ketoacidosis and hyperosmolar hyperglycemic non-ketotic syndrome. Okay? What's the similarity between all of these three? The similarity between all of these three is that they are all conditions that cause, and here's the keyword, intracellular dehydration. Okay? They are all conditions that cause intracellular dehydration. And they will cause that intracellular dehydration by increasing serum osmolality. Okay? Kini man ko siya, class, our hypotonics, since they will decrease the concentration of solutes in the blood. Now they will decrease serum osmolality. Okay? They will decrease serum osmolality. So, yung na siya. Muna siya nakaapan, they will cause intracellular. That's why we should give our hypotonics to this because they have increased serum osmolality. We want to decrease it back to normal. What are our nursing precautions for hypotonic fluids? So this is contraindicated with patients with increased ICP because this might cause what we call cerebral edema. Cerebral edema. This is contraindicated for patients with liver disease, trauma, or burns because, as I mentioned before, hypotonics solutions push blood away from blood vessel and into the ECF. ICF. No? So what happens is because of that, it might exacerbate these conditions. Manubra na class. It might exacerbate these conditions. And monitor the patient for fluid volume deficit. Kanina kay fluid volume excess or overload, this time deficit na. Remember, the reason why there is a deficit is because water is moved from the blood vessel into the cells, di ba? Manood sila padung sa imong cells, no? So, what are our fluid volume signs of fluid volume deficit? Now, lagyan niyo yan ng malaking star class sa ito, The first sign, okay, for especially older adults is confusion and dizziness. Okay? This is your first sign for elderly. First sign, no? Another sign and symptom is decreased skin turgor. Okay, and what else? Dry mucous membranes. Ayan. Decreased urine output. What else? Low BP. Decreased BP and increased HR as a compensatory mechanism. Weak pulses. This is opposite of the of the overload, diba? Weak pulses. And lastly is thirst, no? Physical thirst. Okay? So, muna siya. That is for our hypotonic solutions. Next is our hypertonic. Now, ako yapon i-reason class because this is actually nabaligid siya class, no? Na opposite day gid siya, no? Okay? So when we're talking about hypertonic solutions, this is when the concentration or osmolality of the plasma. When we say plasma, it refers to the blood. Remember? Okay? Plasma is greater than the intracellular fluid. Therefore, the fluids move from the intracellular to the area of high concentration, which is now the intravascular. Okay? Now, this will increase the intravascular volume, which makes it fluid expanders. Now, let's draw it back once again, no? At tuturingon balik ha para makasabot mo, no? So this is our hypertonic. This is our blood vessel. Okay? Yan mo na siya itong cells. This is our cells, no? 1, 2, duha lang. Okay? This is our blood vessels. This is our intracellular fluid or intracellular space, no? Kini nga result sa tungkuan inside our cell. Okay, now, a hypertonic is something like this, class. There is a lot of solutes in our blood vessel. Daghan kayo. Back. While in our intracellular, class, there's very few. Okay, very few. And because of that, class, no, ato sa i-describe balik tristasa so that you will understand, no? So that for further understanding, no, hypertonic solutions is when there is increased solute in the blood compared to the cell. Now, I hope you've noticed something, class. I hope you've noticed something. No? These fluids, class, we are defining its tonicity. Okay? Hypertonic, isotonic, hypotonic. Now, if we go back to the top of the slides, no? Tonicity is referred to as the relationship between the concentration of solutes between two compartments, the relationship. Okay? So, kung mubalik na diri, class niya, basahon na to, class, no? Hypertonic means that the solute in the blood the solute in the blood is increased compared to the cell. Meaning to say, we are comparing that the blood solute has greater concentration compared to that concentration inside the cell. Diba? Inside the cell, no? So, mo na siya meaning sa tonicity, class, inside the cell. Okay, now what happens there is something like this, no? If you remember what I mentioned before, osmosis moves water from an area of low concentration to an area of high concentration. In this instance, mao ni siya ang atong low concentration. Okay? Mao na siya ang atong low. While this one is our high concentration, di ba? High. No, so the water will move from the intracellular up towards our blood vessels. The water. Okay, water will move. In turn, class, what happens is the cells, instead of swelling, they will now shrink. Mugamay sila, class. No? The cells will now shrink because you are taking away or removing a lot of their fluids. Diba? So the cells will shrink. Star. Lagyan mo yan ng malaking star. And then, it will increase, okay, blood volume. Ayan. Because you are putting a lot of fluid into the intravascular. So, as opposed, mura siya opposite anino. Kini mudako ang imong cells, it will decrease blood volume, while this one will decrease the size of the cells and cause what we call an increase in blood volume. Okay? Now, here's the thing you need to remember, ha? If, for example, the cells will shrink, then this is what we call, class, no? Cellular dehydration. Kana cellular dehydration, class, it's very dangerous because, remember, tanawa, cellular dehydration can cause thirst. It can activate the thirst mechanism. Okay, now remember, if na gani kay thirst mechanism, class, you will keep on drinking. Magsikag inom og tubig. You will keep on drinking. And because of that, class, no? Remember, ha? You will keep on drinking. And if you keep on drinking, you are gonna increase the overall fluid volume. But remember, you are also increasing the blood volume. So when you are taking these drugs, listen to me, ha? There is a very high risk for fluid overload. Balik ko na ko, ha? Since all the water in the cells, or most of the water in the cells, are going to your blood vessels, there will be an increase in blood volume. But since your cells have already shrunk, they are now experiencing cellular dehydration. And cellular dehydration activates the thirst mechanism, which in turn causes your patient to keep on drinking. We call this polydipsia. And if the patient keeps on drinking, then they will increase the fluid volume, which in turn also increases the blood volume, eventually leading to what we call fluid overload. Delikado kini siya, class, no? So, what are our hypertonic? Dili na siya hypotonic, hypertonic na siya. It's not hypo, this is hyper. No. Wala, di na ma-erase. Hypertonic. Okay, so we have our 3% sodium chloride solution, so it's greater than 0.9, no? This is for patients with what we call severe hyponatremia, patients with low serum sodium, because this one has a lot of sodium. This will increase, no? This will increase sodium levels, di ba? And this is also for patients with cerebral edema. This is for patients with cerebral edema, di ba? Okay, we also have 5% dextrose with water. 5% dextrose with water. This is for replacement of sodium chloride and some calories, no? Sodium chloride and some calories. No, this is very good as a replacement for electrolytes, no? Replacement for lost electrolytes. Okay? Now, what do we need to consider when it comes to our hypotonic solution? This requires very constant nursing surveillance when giving, because as I mentioned, there's a very high risk for fluid volume overload, in especially pulmonary edema. Okay? Especially pulmonary edema, no? Because if there is a lot of fluids, most of that fluid might leak. Some of that fluid might leak into your lungs. So there's a risk for fluid volume overload and pulmonary edema. What do you need to watch out for when it comes to pulmonary edema? Number 1, as I mentioned before, dyspnea. Number 2 is your crackles. Diba? So what do you need to do to intervene? Put the patient in orthopneic position. Okay, check the prescription accurately. Note the specific length of time of administration, infusion route, and the total volume to infuse. Nga naman, I want to highlight length of administration time, because this should not be administered for a long time. Okay? As I've mentioned before, kinahanglan ni siya, class, i-monitor. We need to monitor this because there is a very, very high risk for what we call our fluid volume overload. And hypertonic solution should be stored separate from the other fluids, class. This is a highlight in the NCLEX exam. Dapat ninyo may numduman, class. This is the highlight in the NCLEX exam. And the reason why is this is to prevent accidental misuse. No, to prevent accidental misuse. Maybe we want to get a hypotonic solution, but since tapad-tapad raman siya, dali man ta, kuhaon na to ang kanang kuan hypertonic, and we don't want that, no? And with that, we are done with our fluids, no? A lot of this discussion is mostly on the drugs itself, mostly on the fluids. If you want to learn more about the computation, then I suggest no that you watch the video tomorrow about computation. But also kung ano, try to practice yourself. Aside from that, most of the information when it comes to the IV infusion is or will be discussed no in your demonstration on IV priming. No, so and with that we're done. Antayan nyo na lang yung just wait for the koan. Just wait for what we call the announcements no on what's gonna happen in the next few days.